Hello everyone, welcome to your YouTube channel. This is Mr. Cash. Again, we are teaching and learning respiratory therapy. Please forgive me if I make any mistake in this video. Also point it out if there is a mistake. Thank you so much. Today we are going to learn about the mechanics of exhalation. The reason why you're seeing this picture is I want to get one point across. Mechanics of exhalation. We are using Egan Fundamental of Respiratory Care to refer to get our information from. In the chapter we are doing chapter 11, ventilation. So the reason behind this picture is I want you to remember that exhalation, which is you have inhalation, the breath going into your lung, and the breath going out of your lung is called exhalation. Okay, now inhalation is an active form of delivering the air to your lungs, right? So let's say this is your lung, right? The air going in is inhalation, and the air going out is exhalation. Okay, all right. Now inhalation is active, exhalation is passive. Okay, and the reason is inhalation requires active muscles. The chest and the intercostal muscles wants to expand, so there's an active form. Also there's pressures that play in, but we're not going to go into detail into the pressures. Okay, I just want to give you the point that inhalation is active, exhalation is passive, which means, why is it passive? Because of potential energy. And this goes into physics. This is why physics is important. Okay, the massive ball of a demolition machine and the stretched bow poses stored energy of position, which is potential energy. Same thing when he is pulling on this rubber here, it is storing energy here. That is getting, this energy will go out anytime he will release this, the bow. So the potential energy, same thing. When you're inhaling, you're expanding your chest, your lungs are expanding, they're storing energy, which is potential energy. Then exhalation is passive, it means on its own. So this is what I wanted to point out first. Now let's go into the chapter, and we're going to continue where we left off. So mechanics of exhalation. Airway caliber is determined by several factors, including anatomic, physical support provided to the airways, and pressure difference across their walls. Okay, so the caliber means, in a medical term, is the diameter of an airway, of a hollow tube. So that's what they referring here to. Let's continue. Anatomic support comes from cartilage in the wall of airway and from traction provided by the surrounding tissue. The large airways depend mainly on cartilageous support. So the large airways, like the trachea, has cartilage around it that supports it to stay open. Okay, the larger depend mainly on cartilageous support. Okay, because smaller airways lack cartilage, so the smaller airways, they don't have cartilage. They depend on support provided by the surrounding lung parenchyma, so support from the lung itself. Okay, the airways are also supported by the pressure differences across their walls. So there's pressures across the walls. This transpulmonary pressure gradient, so alveolar pressure, transpulmonary, so pulmonary is in your lung, okay? Pressure gradient helps stabilize the airways, particularly the small ones, so the small airways. During quiet breathing means during normal breathing. When you're not sick, you're just sitting there, you're just sitting breathing quick. Pleural pressure is normally subatmospheric. So the pressure in your lungs, the pleural pressure, right? Normally, then it's subatmospheric. That means it's below atmospheric. And we know that atmospheric pressure is 760 millimeters of mercury or 0 centimeters of water. So, but in the pleural space, it's subatmospheric. It's below that. Okay, that's why it creates the pressure for the air to go in and out of your lung. Okay, airway pressure varies minimally and is usually close to 0. Airway pressure varies. Okay, so it changes the airway pressure. Okay, atmospheric pressure, the transmural pressure gradient, the pressure difference between inside and outside the airway wall. So the pressures that are inside the wall and outside the wall, difference between inside and outside the wall, during normal quiet breathing is negative. Even during exhalation, it ranges from -5 to -10. This negative transmural pressure gradient helps maintain the caliber of small airways. Okay, so there's the pressures that helps us. Okay, during a forced exhalation, contraction of expiratory muscles. When you force your exhalation, when you inhale and then you forcefully exhale. When you forcefully exhale, you're releasing all that air from your lungs. That's what they're talking about here, okay? If the positive transmural pressure gradient exceeds the supportive force provided by the lung parenchyma, the small airway may collapse. That means if you are forcing it, the air to come out and escape, the pressures drop and your airway will collapse. Forceful contraction of the expiratory muscle causes pleural pressure to increase from its normal negative value to above atmospheric pressure, alveolar pressure, okay, because you're forcing it, okay. Now they're pointing out to figure 1110, okay. So we're gonna go to this figure 1110 and we're gonna try to understand what they mean here, okay. So we said the trachea, this is the trachea. It is supported by cartilage, right? So there's some rings that go around it. That is cartilage, okay? So this cartilage, it supports it, it stays open, right? As you go further down into the alveoli, there will be no cartilage. The less cartilage will be, okay? Now, they're saying there's pressures. As you can see, the pressure here is +10 lung recoil, -5 lung recoil. Now let's read so we can understand here. Generation of equal pressure point, EPP. Equal pressure point. There's a point where the the pressures will be equal, okay? Let me just increase the light. So we can see better. Okay. Okay, generation of equal pressure point, EPP, in normal and distal lungs during forceful exhalation. This is during a forceful exhalation, when you are forcing your lung to exhale, okay? In a normal left lung, pleural pressure increases approximately 20 centimeters. So they're talking about here, okay? When a maximal expiratory effort is performed, okay, when you force your exhalation, force that air out of your lung, alveolar pressure in the sum of pleural pressure and lung elastic recoil pressure, or airway pressure falls along the airway and from the alveolus to the mouth from 30 centimeters to 0 centimeters. At some point along the airway, pressure within the airway equals. So they're saying, you will see here the EPP, right? The pressures are equal here, right? Whatever is inside, it's outside. So there will be no collapse. It will be equal. But once the pressure is higher here and it's less here, then there will be a collapse. Okay, this is only when you are forcing your exhalation. Okay. Now let's continue reading here. Okay. At some point along the airway, pressure within the airway equals pleural pressure. This is the EPP. Further toward the mouth, downstream, airway pressure falls below pleural pressure, resulting in a narrowed airway and limitation of airflow. This narrowed airway normally occurs in a healthy individual only during forced exhalation. This is very important. So it will only occur, the EPP will only occur in a normal adult, which means a healthy adult, only when they forcefully exhale, when they take out all that air out of their lungs forcefully, very hard at one time. The normal EEP moves upstream, okay, from the large airways toward the small airways as the lung empties. In lung disease such as emphysema, right. Okay. So the right lung, the left lung, this is the right side. This is emphysema, and this is normal, okay? In lung disease such as emphysema, which is the right side of the lung, this is the emphysema, and this is the normal lung, okay? So left lung is normal. Let's try to figure this out because I'm getting a little confused here. Let's go back. The EPP moves upstream from larger airways toward a smaller airway as the lung empties. In lung disease such as emphysema, right, the same force comes into play. It's still 20, but lung elastic recoil pressure is only 5. As a result, driving pressure is only 25. So this is the messed up lung. This is the emphysema lung. This is the normal lung, right? But they pointed out the right lung. But in reality, when you look at anatomical positioning, this means this is the left lung and this is the right lung. But they're talking about just here on the book, the right side and the left side, okay? They're not talking about anatomical, which is messed up. They should have talked about anatomical because that's how that's what we use in the medical field. Okay, but anyway, just let's continue. So that means this is a healthy lung. When you force your exhalation, collapse will occur right here. But since the damaged lung from emphysema, it will collapse here because your whole lung is damaged. We know that alveoli in emphysema patients, their alveoli is wide open, is large. Their compliance is very high because remember, the walls of the alveoli are damaged. So elasticity is very weak. There's no elasticity in those patients, okay? The same forces come into play. Pleural pressure is still 20, but lung elastic recoil pressure is only 5 centimeters. As a result, driving pressure is only 25. This causes the EPP to occur in the smaller airways. Further upstream, the normal airways narrow on collapse at a higher lung volume than in healthy lungs. So they're saying here that these emphysema patients, when that happens, since that the collapse of the lung, it happens so early right here, so it restricts the flow of air to come out, and that's why what's called air trapping. So this is actually really bad when this happens in patients with emphysema. As a result, driving pressure is only 25 centimeters of water. This causes the EPP to occur in a smaller airways. Further upstream than normal, airway narrows or collapse at a higher lung volume than a healthy lungs. In patients with emphysema, airway collapse is complicated further by loss of support to the small airways, modified pulmonary, physical, and clinical. Anyway, so the point they're saying here, Now we know that the EPP, where the pressures happen, we said in a normal healthy adult, when you forcefully exhale, right? This equal pressure that happens inside the airway and outside, it collapses the airway. It happens right here, and this is in the healthy lung, right? So that means it happens later on when you're already emptied. So collapses of the lungs will happen here, and then there will be no more air going. It will limit the airflow. Okay, but emphysema patients, since they already have large volumes here in the alveoli, and now they're forcing and the pressures are higher, it collapses faster before it gets to the airway. So there's more lung collapse before when they forcefully exhale than a normal adult, because of the large volumes they have in their lung. In the lung, the higher volumes they have due to the destruction of the alveoli, because the alveoli walls is destroyed by emphysema. So if in healthy adult, you will see an alveoli that is like this. This is I'm just giving you a picture like this, but an emphysema patient will have a huge alveoli because the walls of the alveoli is already destroyed, so it's not elastic anymore. So they will have more volume inside than outside. Okay, let's continue. Now let's go up here and continue reading to go further. Forceful contraction of the expiratory muscle causes pleural pressure to increase from its normal negative value to atmospheric pressure. Alveolar pressure during forced exhalation equals the sum of pleural pressure and the elastic recoil pressure of the lung. During exhalation, the pressure along the airway decreases as gas flows from the alveoli toward the mouth, moving downstream toward the mouth. Transmural pressure decreases continually as one point along the airway. The pressure inside the airway equals the pressure outside in the pleural space. Transmural pressure equals 0. This point is referred to as the equal pressure point, EPP. Downstream from this point, pleural pressure exceeds the airway pressure. The resulting increase in transmural pressure gradient causes airway compression and can lead to collapse. The airway compression increases expiratory airway resistance and decreases flow. As the EPP greater expiratory effort increases pleural pressure, restricting vicinity to cause this flow limitation. The EPP, airflow, recoil pressure determining flow. Dynamic compression of the airway, narrowing of the airway owing to an increase in surrounding pressure, and responsible for the characteristic flow patterns observed in forced expiratory test of pulmonary function. In airways of healthy persons, airway collapse occurs only with forced exhalation in low lung volumes. This is a very important sentence here. So the first paragraph that we just read, which is this big chunk here, it already explained what I just explained to you right here about these pressures, okay? That's why I'm moving along, because it's not giving you anything new, okay? In airways of healthy persons, now they're talking about the healthy person. Remember, this is the healthy side, and this is the emphysema side, okay? In airways of the healthy persons, airways collapse occur with forced exhalation and at a low lung volumes. Tissue support tissue support opposes the collapsing force created by negative transmural pressure gradients. In pulmonary emphysema, the elastic tissue supporting the small airways is damaged. This is exactly what I was explaining to you, that it's damaged. Okay. Destruction of elastic tissue, such as occurs in emphysema, has multiple outcomes. It increases the compliance of the lung, which is the lung is more compliant because there's no airway that are collapsed. Okay. I'm sorry. It increases the compliance because there's no elastic fiber that will cause it from stretching out. So it's very compliant, so it's easier to inflate. That's what they mean about a higher compliance. A higher compliance means that is easy to inflate. Let's say you have a balloon that is already been inflated many times, and then you come to inflate it already, it's already open, it's easier. But if you have like a water balloon, a small balloon, and you try to inflate it, it's very hard to inflate it because the compliance is so hard. It's not compliant. Okay. Okay. Destruction of elastic tissue, such as occurs in emphysema, has multiple outcomes. It increases the compliance of the lung. Elastic recoil decreases. The combination of decreased elastic recoil and loss of support from the small airways allows the airway to collapse during exhalation. Airway collapse causes air trapping. This is what I was just saying earlier, air trapping. So air will be trapped in your lungs. In increasing the resisting volume of the lung, expiratory flow is reduced by airway collapse during exhalation, called flow limitation, and can occur during tidal breathing with emphysema. Emphysema with changes in the lung are severe. Rule of thumb. This is important. Rule of thumb. This is going to be another topic, work of breathing. So we're just going to go to the rule of thumb. Rule of thumb. This is important. This is what you have to understand. Patients who have emphysema can directly influence the EPP in their airways to reduce airway collapse and closure. So what they're saying in this first sentence is any patient who has emphysema can directly influence the EPP in their airways to reduce airway. They can actually control it. And there's ways, there's a method where you can control your EPP. So that way, when you're exhaling, we already said inhalation is active, but taking out that air is passive, normal. But if you're forcing it, and if you're sick, to control your exhalation, taking the air out of your lung, there's a method, specifically for emphysema patients. And emphysema patients, they already know this one. It's natural to them, how they make it easier for them. Now, the second sentence is airway collapse may occur in patients who have emphysema because the normal support structure of the small airways has destroyed. Okay, we know that one. By exhaling through pursed lips, a patient with emphysema changes the pressure at the airway opening. The gentle back pressure created counters the tendency for small airways to collapse by moving the EPP toward the larger airways. This is a technique which is called pursed lips, and I will show you a picture of it. This is what they are talking about. Pursed lip breathing. So they inhale through their nose, breath in, right, into the lung. Now from your lung out, breathing out, this is what they have to do. They have to purse their lip, like if they're gonna give someone a kiss, and they're gonna blow the air, and the air, when it's blowing against their lip, it creates a backup pressure that will cause the EPP to go to the upper airways. It will cause it to go here instead of here. So now the lung will completely empty before it collapses. You understand? Now gas exchange will happen and new gas will come in. It will prevent air trapping. So this is a technique you can teach your emphysema patients to do. Some of them already know it. It's called pursed lip breathing. You can actually try it on your own and see. It creates a backup pressure that will keep your lung open and prevent it from collapsing. Okay? And this is where we're going to leave off today. But today I have some questions for you on this topic. So, the first question that I have for you, it's a good exercise for you. Okay, the first question is, for a healthy individual at rest, which of the following statements about exhalation is true? So they want to know which of these sentences is true about exhaling. Okay? The first one says exhalation will be passive due to the inspiratory stored potential energy. Is this true? Is exhalation will be passive? I mentioned it many times that exhalation is a passive technique due to inspiratory stored potential energy. Okay? Exhalation will only require 40% of energy expended. This has nothing to do with. So the answer is what? We already read it. It's A. We already know why. During normal quiet breathing, inhalation is active and exhalation is passive. The work of breathing, exhaling is recovered from potential energy stored in the expanding lung, in the expanded lung and thorax during inhalation. Okay? Now I'm gonna bring another question for you. In healthy individuals, what may lead to airway collapse? They're talking about a normal breathing person. What will lead to airway collapse? Increased lung recoil. That has nothing to do with what we're talking about. Significant decrease in surfactant. That has nothing to do with surfactant. Maximal inspiration to forced exhalation to RV residual volume. This will lead to airway collapse. If you are forcing your breath to come out, this will cause, remember the EPP, equal point pressure, and the airways will collapse in the more upstream, near to the larger airways. So the answer is D, forced exhalation to reserve volume. And again, in airways of healthy subjects, airway collapse occur only with forced exhalation and at low lung volumes. Now we're going to go to another question. Here comes your third question. Which of the following statements about the equal pressure point is true? As gas travels from EEP to the mouth, greater expiratory effort increases flow. Has nothing to do. At the EPP, pressure inside the airway exceeds pore pressure. No. The EPP normally occurs at a volumes greater below the FRC. Upstream from the EP toward the alveoli probably exceed pressure. The opposite. That's not true. So your answer is C. At some point along the airway, the pressure inside equals the pressure outside in the pleural space. Yes, this point is referred to as the EPP. Downstream, and you keep reading on and on, okay? I'm not going to read this whole thing, but these questions is practice questions on this topic so you can understand. Oh, I have one more question. And it's the last question for you. This last question. In individuals with disorder characterized by, number 4, I'm talking about question number 4. In individuals with a disorder characterized by an increased fractional work of breathing, such as emphysema, which of the following breathing pattern results in the minimum work? So the question is asking you what? They're asking you about an emphysema patient. How should they breathe in order to limit their work of breathing? So if they have less work of breathing, the better for them. So A is rapid and deep breathing. B is rapid and shallow breathing. C is it deep. C is slow and deep breathing. Slow and shallow breathing. How should an emphysema patient breathe? Should they go fast and deep, or fast and shallow, or slow and deep, or slow, shallow breathing? I am not going to give you the answer for this. You have to find it on your own, and you can put it in the comment below. and I will correct you. And if you want to know what's the answer for this question, you can find that out in the comment below. Some people with the answer will put the answer for this question. Thank you so much for watching. I appreciate you listening to this video. Keep learning respiratory, and it would help you in the future, in your future journey as a respiratory therapist. And thank you so much for watching, and forgive me if I made any mistakes. Thank you.